Welcome everyone to yet another series of Surginar. And this is again going to be like a near live surgery and deferred format. And we have a galaxy of operating surgeons as well as panelists in this platform of Johnson and Johnson, along with All India Ophthalmological Society Scientific Committee. I have with me uh, very gifted surgeons who need no introduction actually. Dr. SPS Grewal, Director, Grewal Eye Institute from Chandigarh. Dr. Suhas Haldipurkar, Founder and Medical Director, Lakshmi Eye Institute, Panvel from New Mumbai. And Dr. Sartaj Grewal, again from Grewal Eye Institute, Chandigarh. And Dr. Tanvi Haldipurkar, Director, Lakshmi Eye Institute, Panvel, New Mumbai. Then we do have a galaxy of panelists with us, which include my very good friend, Dr. K.V. Satyamurthy, Director, M.M. Joshi Eye Institute, Dharwad, Dr. Nureha Dholakia, who's very famous for her new invention that she's done on IOL IOL explantation scissors, and she's the founder of Dholakia Eye Care from Mumbai. And of course, Dr. O. Gopalakrishna, Medical Director from Arca Eye Hospital, Nellore, who's also been an operating surgeon before on the same platform. So without much ado, I think we should start the session. And over to you, Dr. S.P.S. Grewal, sir, for your live surgery.
Thank you so much, ma'am. And let me express my thanks to All India Ophthalmic Society and GNJ for giving this opportunity to connect with the colleagues. So can I have my video first, please? So this is, I'm starting the surgery, and surgery is done with Artivo and heads up. So this step I consider the most important, that the first thing is after you have draped and exposed, I have a very good coverage with methyl cellulose so that you're not worried about the cornea during the procedure. I make two side port incisions, 0.9 mm each, and without holding the conjunctiva, just the support. And these are at 180 degrees apart. And then I use Zalocard with adrenaline in all the cases. And after this, I'll be injecting viscoelastic. This is the setup of the OT. And I'm using Veritas. So now this is injecting methyl cellulose. And I go to the diagonally opposite angle, which removes whatever air bubbles are there and gives you a clean view. And then I do the capsulotomy. And I was a little apprehensive at this step because I did a capsulotomy after 1 year. Because I normally do femto, but on the day of live surgery, there was some error in the machine. So I had to go back to my older skills of doing capsulotomy. I managed it without, of course, I managed it, but didn't come out to be as perfect as I would have expected it to be. So I use the technique of folding the capsule rhexis and folding it and placing it in such a way that it takes the path that has been taken by the outer edge of the folded capsule. It's important to hold it away from the folded edge, not very close to the folded edge. So then I make the main incision. So I made the main incision and then I do hydrodissection. I would like to tent the capsule here. And if you see the tip of the cannula is flat and it's pressed against the anterior capsule to broaden the flow of the stream and it separates the capsule entirely from the cortex, and then hydrodelineation. This step normally is not done routinely by me because in femto you don't need to do it. At this stage, I would like to inject methyl cellulose, again going at the outer edge. It also clears the view, gives you a clean view, and whatever air bubbles are there, they are removed. So it's important to remove the cortex and remove this completely up to the nucleus. It gives you a fairly accurate idea where the nucleus is, and you are able to go to the right depth that is required. I use top and chop. The hold at this stage is very important. If you have good hold, then you will be able to separate. And if you have made a cleavage and separated into two halves, then your next steps are going to be more predictable and relatively easy. Try to go deep here so that your tip is in the middle and it is aimed towards the equator of the lens, because that is where you have the maximum of the lens matter available to hold. If you see that the speed at which the machine is taking away the pieces, it's just amazing. You just keep it at one place. You don't have to move it too much. So if you see, the tip doesn't move much. It stays practically in the center. And as it eats away the piece, the part of the piece which is near the tip, the rest of the pieces will automatically rotate and they'll come into the tip. And posterior capsule with the Veritas machine, the posterior capsule remains absolutely obedient and in its place. There's no question of a surge coming in it. The fluidics and the maintenance of the anterior chamber is just amazing. So now I'll go on to removing the cortex, the cortical cleanup. I use bimanual. I like continuous irrigation on in all of the procedure. So go under the capsule, swipe circumferentially, hold and pull towards the center. So once the one half is taken out, then you change the hands. This is loading the lens. When the assistant loads the lens, as the lights in the OT are low, so we have someone to show the light to the assistant. So there was a small fragment of the nucleus which was not going on it. So that is the time how you break it with the irrigation tip over the aspiration port. So now methyl cellulose again, and if you notice that throughout the procedure, there was no need to irrigate the cornea. So this is injecting Helon. I prefer to use Helon in all my cases because removal is quick, complete, and let me use the word easy. So this is a push injector. This is the Pure C. It's a safe lens to use, safe in the way that patients don't compare of any glare or rings in the postoperative period. And at about 45 centimeter to 50 centimeter, they are able to do all the activities. Those who want to read newspaper, full newspaper, and those who want to read novels, normally they'll need a 0.75 correction. So this is a loop which is stuck. So there are two options. One is wait for a minute, or you just touch the loop. You don't have to make any applicable forces onto the optical part. Just probe on two sides of the loop and just nudge the loop and it opens immediately. And then after this, we come to the final step, that is removing the viscoelastic. So I realized that the tip is not proper. So the tip of the sleeve is to one side. So I go back under the microscope. It is still not okay. So I adjust it, then satisfied that it is okay now. So the helon comes out completely and quickly. So the last step will be intracameral injection. Again, from the outside the wound, you reform anterior chamber with antibiotic and put a pad which will be kept for about 2 hours or so. Thank you.
Thank you. Am I audible?
Yeah.
Yeah. No, very, very nice, neat surgery. So I wanted to know if, sir, Pure C in a post-LASIK patient, would you put it?
Why not?
And if the patient wants near, then micromono?
Yes, micro, but
Would you,
not
would
more
you,
than 0.5, not
not
more
more?
than 0.5. I will still try to convince the patient to get it corrected for distance and have reading glasses for those rare situations where you want it. Although all those patients who had LASIK done many, many years ago, their mindset is still the same, that I don't want to use glasses, but then we
Correct.
have our own limitations. We can't use trifocal or those lenses which give good near vision.
Correct. And would
If you,
would you see if it was a post-LASIK, a post-myopic or post-hyperopic LASIK, or it wouldn't bother?
Post myopic is fine.
Safer.
It's safer, definitely.
Sorry.
so one more question. In
Yeah.
the same situation where the post-refractive surgery case, would you prefer a CRV or a FER lens or a pure C lens? What is your choice?
Which
If there
one?
is any contraindication for the CRV lenses,
Which lens?
the Synergy or the ODC lens?
No. I would. My first choice will be Eyehance, and my second choice will be Pure C. I would not like to venture into other lenses.
Sir,
No, why
why
your first choice? Yeah, sorry.
why Eyehance, sir?
Why Eyehance?
Yes.
Because the quality of the vision we all know will be the best with that lens. Contrast will be the best with that lens, and still they are able to manage phone from a little distance. That is why.
Sir, in QC, do you select, I mean, do you the first negative and second negative for the dominant eye and second minus for the less non-dominant eye? or emetro both eyes?
It's a lot dependent upon what the expectations of the patient are or the type of the patient is. If the patient is such who is going to compare the two eyes for distance, I don't think these are the cases which are right for monovision. I know that it works. I know it works. But then is patient ready to accept it? So they have to be very clearly counseled that, okay, I can make you more spectacle free, more percentage of the time spectacle free, but then you have to be ready that your distant vision will not be the same in both the eyes. Otherwise, a patient will be fine in reading and he'll come say, okay, my vision is not good for distance.
Yes.
One tip that I do, this is not related to the case, but whatever viscoelastic I have, we don't use it in the next patient. So while we put it on the cornea, I also put it all over the conjunctiva. And I've seen by doing that, the patient's post-op complaints of dryness are a little lesser or not there.
You are
So
absolutely
anyway, it's going waste. So just use it. I even pad it with that.
yeah.
And the other thing is when we place any lens, since the vertical diameter of the cornea is shorter than the horizontal, I prefer placing the lenses in the vertical direction, especially these lenses which have a central zone that causes less rotation and less shifting of the lens. That's what I feel.
I think you have a logic in what you're saying.
Yeah. Thank you, sir.
So,
So,
madam, can you elaborate on this? I mean, we are going to put it in the bag, no? So bag dimensions
So
are going to be same.
correct. But I don't know, so I'm not saying whether it is technically correct or no. But we know the white to white vertical is smaller than the horizontal, so the lens would be a little more compressed and less likely to shift. You all can try it out. Not
Nice
that
tip,
it
madam.
shifts too much, but
Yeah,
just
thank you. Thank you so much.
just a little out of the box thinking. That's all.
okay. Thank you. And so now we move on to the second case, and the second case is going to be by Sir Dr. Suhas Haldipurkar. Yes.
Thank you.
So, second case.
Can I take over, ma'am?
Yes, surely, sir.
Yeah. Is my screen seen?
Yes, sir.
Yeah, thank you so much. I would like to thank you, ma'am, the AIOS, and Johnson & Johnson for this beautiful opportunity to share my, video, my deferred live surgery. Very funny thing happened when they came for recording my case. It was recorded well, and just before I was about to put my lens in, of all the things, my patient developed intra-op hard eye, something that I'd never seen in the last 15 years. So I had to go for the next case. By then the record, the guy who had come for recording had gone. So this is my recording, in-house recording. Now, to talk about this case, I prefer to use a 0.8 side port. Grayval is using 0.9, I use 0.8, and I make single. I always use intracameral oculan for whatever benefit it has. And of course, sodium hyaluronate. I use 2.4 keratome. I only make one single side port because my cortical aspiration is done with coaxial, and goes without saying that all my rexes are done with this micro rexis forceps, which bears my name. I prefer, if the patient is cooperative and looking at the light well, I use it to keep my rexis around it. My aim is to get around 5.25. Sometimes I err on bigger size, I may go up to 5.5, but normally I would ensure that my lens will always have an overlap. Either it is symmetrical, or sometimes it may be a little here and there. I use McIntyre's flat cannula. It's a minimal hydro. The first wave of hydro crossing is the endpoint for me. And then, of course, I come out and inject little visco. And for me, the end point of hydrodissection process is when I go with my blunt chopper and ensure that I have a nucleus that's rotating. I normally prefer to do chopping by using burst mode and then quadrant removal in the usual way. So I go with my bevel down, clean up the cortex. Now this is the second time the cornea is coated. Go into trench and make a small trench in the center so that when I want to purchase my nucleus, I'm at a depth so that the purchase is better. And that depending on the hardness of the nucleus, my settings, phaco settings could be 25, 30, or if it's a hard cataract, it could be as high as 60 in my burst mode. And in my cataract, the only time I use a longitudinal energy is when I'm doing my burst. I have a habit of chopping it into multiple pieces. If you have a good purchase, you don't have to go with your chopper to the periphery. You can just separate them. And this is aided by appropriate energy use, because in this, if I use around 60 or 70, it literally buries into and emulsifies it, and your grip is lost. So now that I have done it, cut it into multiple pieces, I quickly go to my quadrant mode, and there I'm using the Ozil technology. If you notice my settings, I prefer to have panel setting where my vacuum and aspiration flow rate are panel set. My entire surgery is done with an IOP of 30. And with good purchase that you get all along, your phaco tip literally has to travel minimal. So it stays in the central safe zone, and the nuclear fragments literally come to it. So at this stage, I have a habit of going for my second round of hydro. That's when I flush the posterior capsule of the remnants, and then I go to the periphery and loosen up the peripheral cortex. It helps me get it quicker and better. My habit, my habit is to always use coaxial for the simple reason that with coaxial, the amount of fluid going into the eye is almost double of what bimanual sends. Naturally, it keeps your ACD and the capsule further away from you. And secondly, it's much quicker. And if you have got a hang of it and learned it well, your subincisional is normally not an issue. At this stage, once I'm sure that most of the subincisional cortex is all cleaned up, especially when I'm using premium lenses or in eyes which have high myopia or a young age, I prefer to do anterior capsular suction polishing. Very subtle way you can clean up most of it. And after that, it's time for us to inject the lens. In this case, I'll be using the Odyssey, the new lens from Johnson & Johnson. It has got its own injector, the Technis Simplicity. You inject viscoelastic, screw the lens, and when it almost comes to the plunger tip, you go with the side port to spatula in the side port to stabilize, and the lens is gradually inserted in. It needs to be done, at least I use visco delivery, where the bag is filled with viscoelastic and the lens is delivered, most of it. Sometimes the haptic stays, but you can always go with the second instrument to dial it in. And the beauty of this lens is that it's on a Technis platform. That says so much about it. The Technis platform, see, it's a best contrast in that class. It has the distinction of giving you continuous smooth vision.
Yes.
And then once the lens is in,
Lens
this is Johnson & Johnson Odyssey. It's a trifocal EDOF. Once the lens is positioned in its proper place, I go with my irrigation as my coaxial. It's a Freedom diffractive profile that is used here. And the beauty of this lens is that continuous range of vision. There's less segmentation. There's more continuity. And it's more of a blended defocus vision. In fact, some of its features are, it has enhanced tolerance for refractive error up to -0.5. If you talk of dysphotopsia, in the class, the least amount of dysphotopsia is what you get with this. It almost compares with monofocal, at least in contrast. And after that, one step that I always do is go with the irrigation under the lens and wash out all the viscoelastic and all the residue, because that is how you let the posterior capsule stick well with the lens posterior surface. And I have seen among all the lenses, years later, when you see a Technis lens, the shine and the crystal clear capsule that you see with this lens is something, speaks a lot about this technology and the platform on which this new lens has been built. So if you have to talk of optical philosophy of this Odyssey, it is a continuous, uninterrupted focus as against other trifocal lenses where it is distant, intermediate, and near. It gives you an excellent range of vision, but when it comes to very fine print, sometimes it may fall short. But overall, the patient satisfaction with this is amazing. Another thing that I do, I normally don't hydrate because there's only one side port, it's a small side port. I just hydrate the main wound and that is all that I do. And the last step that I do is I burp it a little just to ensure that I have not overhydrated and made the eyeball tense.
Tuesday.
Thank you.
Thank you so much, sir. It was just like a textbook, like picture of a case.
Thank
The
you.
way we actually should be doing it, everything was done. Any question from the panelists?
Dr. Suhas,
Yeah.
for a non-toric IOL, do
Yeah.
you prefer any particular position for the haptics to be placed?
Well, not really. For me, as long as the lens is sitting well inside and it's well centered. See, very often what I do, even if we know that the lens is going to stay in the center, at the end of the case, with the irrigation on, I'll go through the side port with the spatula and press on the lens in the center and make sure I visibly see the lens literally going back and get flat on the posterior capsule, and then I come out. So this way, I consistently find that post-op, visual results are consistent and the lens is always flat.
But some patients do complain of the edge scotoma, like the temporal shadow, they always complain.
Well, in my practice, I have seen one thing. I will have practically everyone talking about the edge glare in the first 10 days, but then after that, normally it disappears. So I kind of prime them. I said, look, you are going to see it. And when he tells me, yes, you see it, and in 10 days, it's going to go. Sometimes I say, maybe in 10%, it may stay for a couple of months also, but don't be bothered. So it all, I have realized that it depends on how much importance you give to their symptoms, because we know that all those symptoms are practically going to go someday. Because in my 45 years practice, I didn't have to remove one lens for that complaint. So that means eventually these symptoms go, and how much importance you give to them when the patient talks to you about them decides how he's going to receive it and accept it.
But in my practice, what I observed is, if you place your leading haptic a little 10 degrees off from the horizontal axis superior-nasally, and the trailing haptic inferior temporally, little from the 10 degrees from the horizontal axis and 180 degrees axis, the patient will tolerate better from the edge scotoma. That's what I observed in my practice.
But how long will that edge scotoma last?
I think in my practice, at least 2 to 3 months, the patients keep on complaining that. There are 2-3 ways of addressing that, but this is the best way, this is the easiest way to address. If it's a non-toric IOL, but toric IOL, anyway, you can't help it. You have to keep the gases only.
It's a very good point. Will you please repeat exactly how you do it? Because it's very important. All of us would like to know. After the lens is put horizontally, you shift it 10 degrees. Huh?
Yeah, 10 degrees, the leading haptic, superior-nasally, the trailing haptic, inferior temporally.
Okay.
10 degrees from the horizontal axis.
Okay.
I think there are a couple of papers also describing this technique to avoid the edge scotomas.
Okay.
Maybe Dr. Sharma, Mama Sharma might
Yes,
add to
yes,
this.
no, I completely agree with you, Dr. Gopalakrishna. Even I have read those papers when we were doing a talk on dysphotopsia, that rather than placing the lens, horizontally, if you place it vertically, the scotoma is less.
Yeah.
No, like how Sir said, Dr. Hardipurkar, it's not a big problem at all. I mean, just all you have to do is just reassure the patients and they settle well, isn't it? So nowadays, I mean, negative dysphotosis is not a very big problem. And
I think for the
as you
edge
said that-
scotoma, for the edge scotoma, there was a different thing for the right eye and different for the left eye, as far as I remember. But as Dr. Haldipurkar said, it's not such a big problem. To just reassure and you don't give it importance. Sir, when you polish the capsule now with this dead bag syndrome, that's not a fear at all?
Interestingly, that's a very good thing. Probably I have removed or treated maximum number of dead bags because because I'm practicing for a long time. It may be around more than 100 cases, and practically all of them are mine. But it has nothing to do with the polishing, because I had a study where I would do polishing of all cases. In one half, in one eye, I would put that Sion edge. In the other eye, I would put the Elcon Ecrisol. And in the initial first 50 cases, all my dead bags happened with one particular type, and it never happened with Elcon. But today, in the next 50, I've seen practically happening for all the materials, like hydrophilic material, and practically every. And I had stopped doing polishing totally after the first 5 years. But all those cases where I never did polishing also had this. So I don't see any relation between
Difference.
and
For polishing also, there's a very nice sweeper, which just like
Yeah.
Jadu, it does it so well.
Yeah.
That's also good. And another question, what happened to that first case?
Yeah. Oh, that's very interesting. That patient had intra-op hard eye. Hard eye meaning what? Absolutely, then it was difficult because I had injected viscoelastic so that I would put a lens, and then the eye became hard. So the only way, immediately I did indirect. I called my VR, and there was one sector, suprachoroidal, which was creating a mound. Okay, so now I had to postpone the case. What I did, tried to go with my spatula to get as much viscoelastic out as I could. And when I knew that most of the viscoelastic is out, but still there was some, I went to the irrigation and tried to get as much as out, and then put the patient on mandatory. In fact, I gave him Intra on the table also. I waited for 1 hour to see if the pressure comes down. It didn't come down. Then, because I knew that patient, I went to their home in the evening at 8 o'clock to check if the patient is fine as a courtesy call, and felt the eyeball was stony hard. Now imagine this.
Oh my
Yeah.
God.
And patient was on Diamox, patient was on atropine, patient was on 60 milligram of these prednisolone. And next day morning, I call her up. I said, "How are you?" She said, "Doctor, I'm so fine." Huh? She said, "I'm absolutely fine." So then I'm kind of preparing. Now I'm going to put that ODC and show that case to you. It will be interesting case. Then patient comes to the hospital. First, I do the refraction 6/6 with plus 11, right? And I see the patient on straight line. You can't even make out the patient had surgery the previous day, so quiet. Then I send the patient to my VR. VR is my son-in-law, Dr. They were there. He sees the patient. He says that Mont's still there, and by textbook, you can't touch the eye, even if the eye is absolutely soft and normal, wait for a week. So coming Monday, the patient. So
Did you take a suture, sir?
no.
Nothing.
No.
Okay.
I just washed it and I was
That's
seeing.
fine.
Thank you for asking.
Thank you so
sir.
Is
much.
it easy?
Yes.
Sir, is it easy to open the bag again to implant the lens in the bag
Yeah.
It's only
after 1
one.
week or 10 days?
1 week,
Yeah.
nothing.
You can open the bag.
After 11 years also.
No, without lens. Without lens. FAK guy.
Ah.
No,
Without
yeah,
lens,
okay.
sometimes it's tough, no?
Another interesting thing I saw on the first post-op days, the AC was quiet, and the posterior capsule within the rexis area, it was kind of, fluttering.
Oh, that's a good sign actually.
Good sign, yeah.
Okay, so I think with this we come to the next part of the Surginar, which is going to be done by our young brigade. And now I would request Dr. Tanvi Haldipurkar to show her deferred life surgery.
Sorry, can you see this video?
No, Tanvi, we can see your
Download.
download screen. Yeah.
Yeah.
Thank AIOC and J&J for giving me this opportunity. I is this seen or it's
Right.
fine? Yeah, okay. So I am operating on a patient today and showing you the pure C lens. So let's begin. This is me, and this is a normal step that I do for all eyes is where I wash and then I use a bud to just clean the lid margins. This really helps to keep the oily particles away, and once I've put viscoelastic on the cornea, it gives me a very good visual field and I can see very well. So I normally make a temporal 2.4 millimeter incision. The viscoelastic methyl cellulose has gone onto the cornea, and to make sure that I don't cause any of these small hemorrhages or any kind of damage to the conjunctiva, I always use a bud to take a counter traction, and I do a 2.4 millimeter incision temporally. Most times it is 5 degrees off from the horizontal axis. That's where my SI seems to be at its minimum. And this is a patient I'm operating under topical, so I always inject some Xylocard with adrenaline. That helps to keep the dilatation also, as well as the pain factor less. I always stain my capsule, whichever the case may be. This must be many thousands cases in, but somehow I feel that the use of the stain methylene blue does tend to give my capsule a little bit more strength, and it works a little more predictable. I always use sodium hyaluronate because I make my rexes through the main incision using the Haldipurkar forceps. So I need a little bit of the anterior chamber depth to be there, and I need it to be stable. So I use a 1% sodium hyaluronate. I make 0.9 millimeter two side ports. Normally they are 180 degrees apart from each other. And I try to make them just at the limbus, more in the cornea, so that there is not much of conjunctival billowing eventually, because I also use a bimanual cortical aspiration. So the rexis is aimed to be somewhere around 5.1, 5.2. Most times I take the guidance of the iris and the pupil, which is dilated and circular, but if there are times when you want it to be very precise, we can also use a Varion overlay. Now over here, since I was implanting a pure C, I wanted the lens to be very well centered, and I wanted it bang on at the 5.2 millimeter. So I was using a Varion overlay, although we can't see it here. Once the rexis is complete, then the next step that I do is the hydrodissection. You can see that there's a bit of cortical cataract there. So most times I always anticipate that the flow of fluid would probably go differently if there's some cortical cataract present, because that would not have the plane of least resistance at the area of the cortical cataract. But I do check that. I always only do one wave of hydrodissection. If I need to do it, it will only be after I have checked and made sure that the fluid wave has passed all over. And I am using a dialer through the side port, and I make these small C-shaped movements at one side only to try and rotate it. I believe this step really helps to loosen out all that cortex which might be stuck at the periphery, and just dialing it 1 or 2 times little extra can help loosen them. So my method of nuclear management is to do it with a direct chop technique. I use a blunt chopper, and I use the burst mode. So this was a deceptively hard cataract. It didn't look so at the beginning, but I shifted my power to around 50. 50 was my power. I was using a vacuum of 550. I'm operating on the Centurion Alcon system, and the chop mode is always in the burst mode, where there is less on time, more off time. And my preferred technique is also to make small fragmentations of the nucleus, sort of like a femtocataract. And I think the reason I like this technique is because it tends to keep the bag still inflated. So although this is not a subluxated cataract or does not have any other complications, but if it was, it would keep the bag very well inflated. And a little different thing that I do while I do my emulsification is that I tend to keep a bit of epinuclear plate away. So when you see me take the nucleus towards the center, it is actually only the hard part of the nucleus that I am trying to nudge towards the center. So if you observe, the phacoprobe always stays in the center. There is an epinuclear plate which is staying back at the periphery, trying to keep the bag still open, and my chopper is the one separating that. So I really think this helps a lot. Again, there's a logic to it, because the power that we need to use to emulsify the nuclear fragments is going to be much more, and the power that I will need to then use to remove that epinuclear plate is going to be very, very less. So by doing this, I am reducing the total power that I'm giving to the endothelium, and also it's kept the bag very well inflated. So here I am at the end of my nuclear fragment emulsification, and now I have shifted to my epinuclear mode. So in this, the advantage is that my power has come down to almost 15, and my vacuum has also come down to around 220. My flow rate remains a little higher, somewhere around 34. And you can see that just by using the chopper without really moving your phaco probe too much around, I'm able to get the entire epinuclear plate in less than 10 seconds. So this feels to be a much safer way in case you've encountered any trouble. Also, the epinuclear plate can be removed very safely. So once that's done, I will be now doing the bimanual cortical aspiration. So the reason I like doing bimanual rather than the coaxial is, one, because I feel that the tangential forces work a little better in my hands, and in case of any small particles moving around, I can always visualize them better because the irrigating flow is moving in a different direction versus what's being aspirated. So the vacuum I use here is somewhere around 350. I always like to do it a little methodically, so I will do the left hemi-quadrant at one go. And there was a little bit of an air bubble there, so I was asking my assistant to clear that so you can see the video a little better. So from one side, 180 degrees of the cortex will be removed. I change hands, and the same from the other side. So in this, there wasn't much cortex on one side, but you could see that there were some fragments stuck on the posterior capsule. So over here, what I really like to do is a hydro polish. So with a 5 cc syringe, I use a cannula, irrigating cannula, and I just try and make the anterior chamber a little decompressed so that the posterior capsule is tenting up. If you fill the AC too much, the PC is going to billow down and you won't really be able to do this step. So the trick here is that you need to let the AC decompress so that the posterior capsule is tented up, and then you need to wash that PC. So if you saw, there were those few fragments which immediately went away with this hydro polish. And now in goes the methyl cellulose. At this stage, I don't use a sodium hyaluronate, I use methyl cellulose. And here comes the lens which I'll be implanting. It's the pure C lens. It goes in through a 2.4 millimeter incision. I really like this injector system, one, because I like the screw type of injector. The thing we need to remember is you need 2 hands to do it. So it's important that it is not wound assisted, but rather you've gone in the wound. And most times what happens is, while trying to screw it in, you might be just going in through the stroma and you're not really in, and then wound assistance becomes difficult. So what I did is I just went back, tilted the tip a little downward so that I was bypassing the stroma and went in. And another small trick that I do is that the plunger, ideally when we push through and through, the lens really goes to one end. So the minute that trailing haptic has come out, I actually start reversing the injecting of the plunger so that it goes back in, and I have not really pushed the lens very much to the other side. It's just a small trick, but I feel that it really has helped me not to shift or push the lens too much in. Once it's in, it's only a matter of time where we need to place it. Now this was a toric lens which had to be placed in its correct position. So at this stage, I do go ahead and use a coaxial aspirator because it does get in a lot more fluid in, so my AC is better maintained and I am able to get in all of that viscoelastic out faster. The center, once cleared, then I again go in with just a single irrigating cannula. Now this is mainly to remove the parts of viscoelastic from the posterior part of the lens, because one, it's a toric lens, I need to put it in its correct place, I need it to be flush to the posterior capsule. So, and you can really see the waves of viscoelastic moving, because I use a viscoelastic implantation of a lens. This is very important for me to do. I need to make sure that the entire part is cleared of it, otherwise one can expect slight raised pressures post surgery. So here I am just dialing the lens into the correct position which was required for the toric IOL implantation. And another, so this was right at the end of the surgery. After I have done a little bit of hydrodissection of the main wound, I normally make it a point to dehydrate the side ports. This has really helped me, keeping the eye very well and stable, is because I have not overhydrated any wounds. In fact, the main wound is also only hydrated at the bed. I normally don't go around to the sides to hydrate, and by just doing this, as you can see, the eye is quite stable and very well maintained. So thank you very much for having me. That's all from my end. So just to talk about Pure C for a minute there, I will take another half a minute. This is a aspheric lens, and the more important part is it's the only refractive platform from Johnson & Johnson that has come, and it is a sort of full range of vision lens without any diffractive rings. So what it is trying to give our patients is that it's able to give you excellent distance, great intermediate, and even some semblance of near. Now, because it is giving you a change in the power, and which is kind of at the posterior part of the eye of the lens, the patients don't really get a lot of dysphotopsia. The kind of profile that a monofocal lens will give is what the Pure C lens also gives. And as Dr. Grewal was talking about it, the patient is very comfortable to read even at 40-45 centimeters without glasses, and if they need to have very fine reading materials, then we do prescribe them a near power of around 0.75 to 1. So that's Pure C for you. I'm open for any questions if you have.
Thank you, Tanvi. I think that was an excellent demonstration of your technique, your surgery. And the thing that I found a little bit amusing was the dehydration of the hydrated wound. So I think the reason perhaps is because you don't want to have a very high intraocular pressure, something that
And
we
also,
didn't
I
think
somehow
about.
feel that the white cheeks that we've all done during our residence, you'll end up making those big fat white circles on.
Yeah, cheeks. Okay.
Don't look
All
so
right.
good. I don't think that hydrates them in any
So
way. It
what
just
is your
makes it
go-to
look bad.
lens, Pure C or Eyehance?
Ma'am, it depends on the type of eye that I'm dealing with. So ESCRS fortunately has now come up with this guideline where they've explained that the range of vision is going to be, so even a monofocal lens can come into a range of field vision which is limited. The Eyehance stretches it a little bit. Pure C stretches it even a little more. So somebody who has contrast problem, somebody who has some kind of retinal issues but does want some range of field, he's not a person who wants to read very small letters, Eyehance is still a great lens provided he knows that we are going to he's going to need glasses for reading. Whereas with Pure C, what I've observed is that these are great lenses for patients who are not very finicky for reading, and that so we've implanted around 40-45 lenses bilaterally, and out of them I would say around 75-80% of patients have not bought lenses, although they need them. When we test them, we've seen that they need a +1 ad, but when asked have you made the glasses, they've said no. So I mean that's a great feedback from the patient. So that's where I believe that this lens site sort of scores. Another point that I have started looking at is I do look at the spherical aberration which is pre-existing in a patient. I still don't have any data to back it up and say that this is how it works, but I feel that if somebody has a slight less negative spherical aberration to the tune of 0.2 or so, the Pure C works really well, versus if somebody would have a very less negative asphericity or spherical aberration, I'm not sure if Pure C will be something which can give them emetropia. Again, I don't have data yet, but we are studying this, and I believe some data from Dr. Gatinal I think will come soon enough to help us understand how each lens will behave differently in eyes with different spherical aberrations. So that's something I have been looking at as well.
Thank you so much, Tanvi. Thank you. I think now we will come to the last presentation by Dr. Sartaj Grewal, and over to you, Sartaj.
Thank you, ma'am.
No?
I'd really like to thank AIOS and J&J for this opportunity. If I could have my video, please. Thank you. So we'll good. We'll just jump right in. So I'm doing the capsulorhexis. I do like to do my capsulorhexis with a cystotome, and I like to use the 30 gauge cystotome, which is a little finer, and I feel a little flexible and actually just a little more forgiving as the eye moves around versus a 26 gauge needle. I do like to do it through a smaller side port incision and make my main incisions a little later because, again, with those intermittent cataracts, I feel the AC is just a little better formed and gives me more control, lesser chances of any leakage of viscoelastic as I'm working. Again, hydrodissection, I think, is the most important step of surgery, really decides how long you'll take for subsequent steps. I do like to do a hydrodelineation also because I like to remove the epinucleus and leave that epinuclear plate to act as a cushion, especially in cases which are a bit more complicated. I do not like to rotate my nucleus because I feel it's just easier to sort of divide it when it's stable. And I have really not found that when I do rotate the nucleus, it's easier for cortical removal. I find a good hydrodissection really takes care of that very well. I do use the Veritas platform for phacoemulsification. Like Dr. Haldipurkar said, I also like to keep my aspiration on panel, but my vacuum settings are linear. So I feel it just gives me more control to modulate the amount of vacuum once I have a hold. Because the panel, I mean, aspiration, I just need all of it, but vacuum, there are situations where I'll want a little more, a little less, depending on the density of the cataract. I do a primary chop and then I do a cross chop where I will go and divide the heminucleus on the right and then emulsify and take out those pieces. Again, maybe this is because I don't rotate the nucleus even after hydrodissection. So I feel I can actually get half of the nucleus out without any kind of rotation. Obviously, denser cataracts, I will go ahead and rotate and divide them into multiple different pieces, but relatively softer cataracts, I feel it's quite easy to just make 4 pieces. Then I will go ahead and remove the epinucleus. Again, if you have a good hydrodissection, it's very easy. It comes very quickly. I prefer to just keep one mode for the entire surgery. So even this is being done at an aspiration of about 46 and a vacuum of 560. I really don't like to move the phacoprobe too much. I'm always trying to come back at the wound, allow the fluidics more space to sort of act and improve fallibility and get the pieces back to you. Um, I like Tanvi. I also prefer a bimanual for irrigation and aspiration, especially when you're doing a lot of flax because those cortical fibers are just cut. It's always important to go in with the bimanual, remove them. So I went in and you could see the iris sort of prolapse. So now I went back in and now if you see I'm angulating the irrigation probe so that the fluid is going over the iris rather than creating a positive pressure under it. So if you have an iris that is popping out of the wound when you go in with the eye probe, you can just change the angle at which you're holding it. And again, with the tornado technique where you're applying sort of tangential force to pull this, it's much gentler on the zonules. So even cases with pseudoexfoliation or weaker bags, it's very easy to just remove this cortical matter without causing any stress. Again, if you have a good hydrodissection, I feel there's very little cortical matter there for you to remove. And polishing also becomes much easier at the end. So we can see the PC looks pretty decent. I will still go ahead and just polish it up a little bit. Again, I'm aiming for about a 5.2 millimeter capsulorhexis. I think today I'll be the only one implanting a non-toric lens. So this is going to be the Pure C. I like to use Helon when I'm implanting the lens because it's the end of the surgery. So I really want to get all that viscoelastic out. It metabolizes faster than HPMC, so fewer chances of any kind of IOP spikes the next day. Again, the Simplicity by J&J is just an excellent platform for implanting the lens. It's fast, but these haptics do tend to stick a little bit, so you have to give it time, or you can go in with 2 instruments and just manipulate the haptics a bit. It's an amazing refractive platform where if you did not know, you would not guess it's anything but a monofocal lens. There are no zones, no rings, nothing that tells you it's any different than a monofocal. Again, plenty of people have spoken about this today, but I think, where it sort of edges out vis-a-vis other refractive EDOF platforms is some studies have shown it gives better contrast sensitivity. And as Dr. Haldipurkar also had said that that's one sort of core quality of the Technis platform, that material, that it gives excellent contrast. And it is giving slightly better range of vision than others. And I think it's an excellent lens, especially, how I would usually break it down is I'll tell a patient that if you want full range of vision, you go in for a diffractive platform. But if you are averse to any kind of dysphotopsias, then you go in for this. And if they're still confused, I'll tell them that if you have glare, you have to deal with it. There's no choice. There's no solution. There's nothing that you can do, and the glare or the dysphotopsias will go away. But if you're struggling with near vision, you put on glasses and it gets better. And we can see those white cheeks that Tanvi is not fond of. Sorry, but I do like to just make sure it's nicely formed. Can be a little gentler on the hydration in future. Thank you.
Thank you, Sartaj. That was quick. And I think each one of us have our, small tips and tricks which are given and which actually helps a lot. Like Tanvi said, I dehydrated a little bit. Like Dr. Gopala said that I make it infratemporal, supranasal. And, yours also, like you said, I do more hydrodissection, then try to move it. So, all of that cumulatively adds to what is not given in the books and what you only know when, some experts, they do the particular thing and they teach you. So I think, can we arrive on a consensus? Monofocal is out, but when do we give, and I know that Synergy is there in India, although Synergy is discontinued in US. So when would we implant enhance Synergy or, Odyssey? Sir, Dr. Grewal, sir.
You say, as you said, that monofocals are out, and my choice is limited to iHands and Pure C. And sometimes for housewives, I may go in for a trifocal because the near vision advantage is there. If put very straightforward, if the patient can afford, I'll go in for Pure C. It's as simple as that.
How about you, Dr. Swaz Haldipurkar?
Well, Pure C undoubtedly is a good lens, but now, we have still not seen the power of Odyssey. That's a beautiful lens, meaning if you look at the defocus, it's kind of smoothened out, and practically most of near vision, except very close, like up to 40 centimeters, it gives you beautiful. So, and see, what's important is for your distant vision, that kind of clarity and better contrast, all these things really go in favor of Odyssey. So I cannot talk much because my experience is very limited, but I look at it as a very powerful lens that's really going to make a big impact. So finally one should remember what platform your lens is based on. If you have a platform which has been for years together proven to be good for contrast and good for sharpness, then I think this is a great lens one can look forward to.
Dr. Gopala Krishna.
Yeah, I think iHands has taken over my advanced monofocal, has taken over all of my monofocal levels. That's period. But I have my observation for pure C lenses is, if the patient is having a pre-existing myopia, the patient will not be very happy with the pure C lens, because all these years they have been used to reading a little further distance. The pure C will not be able to give them. I think I was using Synergy lens for all these patients all these days. But now I think Odyssey is being preferred by me for these patients where the patient needs a little more closer reading distance, because Pure C will not give them the results. The Pure C for all other patients, Pure C is the best lens for me. even in a comorbid conditions like a little bit of early AMDs or early diabetic retinopathy also, I'm using the QC lenses because the way the contrast enhancement is there, the contrast sensitivity is there in these lenses, that will not give any problem for these patients. And even my retinal colleagues also agree to that because they will not be having any problem to do any photocoagulation or any for that matter, any vitreoretinal surgeries, all those things also. The QC lens fares better and compared to the Odyssey. I think Odyssey is being introduced only for the couple of months only. So I think it will take a little more time for us to assess it exactly. That's what my take on that.
Yeah, quite right, actually. And IHAN was a very clever marketing, I thought, because its price was such that it was only very slightly more than the monofocal. So it completely swept the market. That was,
Yeah.
I think, a very intelligent marketing by J&J. Dr. Satyamurthy?
Madam, and like how Dr. Grewal said, I feel I hands way score over the PUC.
Sure, say.
Even the PUC is good, but the patients are not all that happy because they pay more. So
Yeah.
hands which can give better results, they pay less.
I was
So
about to ask Dr. Grewal, sir, why do you think? But now we know the reason because they paid.
That is the only reason, yeah.
So they
yeah,
expect.
yeah.
Dr. Neha?
Yes, sir.
I wanted to know if anybody's compared the Rayner Galaxy with the Odyssey.
I think Odyssey, the problem is it has been only recently introduced.
Correct.
And all of us have done very few lenses.
Correct.
Yeah. And Rayner Galaxy, I think
Came out a little earlier.
I have not used Rayner Galaxy, but others, if they have used, they can tell about their experience.
I've used quite a few, and I think it's exactly the same like Odyssey. It gives you very good reading at 40. Since Odyssey was not there, and some of the patients who did not want the trifocal rings at all, either a relative has put and they don't want it, I started putting Rayner for them. And if Odyssey also promises the same quality of vision, which I'm sure it will because the material of J&J is just superb. I think we have a winner there because with the Rayner Galaxy, I was getting very good near and very good distance, and out of 10 patients, hardly 2 would mention the halos and glare. While in Synergy, Panoptics, any of the typical trifocals, they would all, even if they didn't complain, they would say, yes, I do see the halos and glare. And then there would be 2 who would like just hammer you for some time, and then there would be 1 out of those 10 who would go on for 5-6 months. So that problem will not be there with this.
How do you compare the ease of implantation with the Rayner Galaxy and the Odyssey?
So Rayner Galaxy is preloaded, and this is so both are good. One is a push type, one is a screw type. That's about it. The other difference will be one is hydrophobic. This one, the J&J one, that is hydrophilic. The third thing is this is a diffractive lens, while that is a refractive lens. So that refractive may be having a little edge. We don't
Hydrophilic,
know.
all of us are a little wary of putting hydrophilic.
That's what I'm going to ask you. Hydrophilic is a little bit wary.
Yeah, although they may say, this is pseudo-hydrophilic, whatever, but that thing is. So, Sartaj, what is your take?
For
The
PCO.
edge of the Rayner Galaxy is a little differently modified, no, to just avoid this posterior capsule opacification. Am I right, ma'am?
Yeah.
Sorry, yes, to prevent. But ultimately, any hydrophilic is a hydrophilic. We will see more PCO, come what may.
So, Sartaj?
So I think it's excellent that we're at a point where we have all these options.
Choices,
I think it's when you break it down to most patients that it'll either be distance vision or near and distance. Many of them are taken aback because it's almost like offering a knee replacement, which is with this one you can either only stand or with this one you can only walk. They're like, I want to do both. I have to see distance, I have to see near. But I think it really boils down to obviously comorbidities aside, what compromise is the patient more open to? Is the patient more open to nighttime dysphotopsias, or is the patient more open to using glasses for near vision? So I think it really boils down to the patient. Generally, yes, if the patient leaves it to me, I would go with the Pure C. I think the only sort of factor that we haven't discussed is pupil size. It seems to be forgiving right now, but yes, some of those patients with smaller pupils might have some difficulty with distance vision. But the other thing is, if these patients go elsewhere, someone does an auto ref, they're going to prescribe them minus power glasses and they will not be comfortable. I have seen a good number of POC patients who were given myopic correction and they had horrible asthenopic symptoms and they came back and they said, better off without the glasses. So maybe avoid progressives for these patients, progressive glasses. It's best to just give them a pair of 0.75 plus one readers, which they'll probably misplace after some time and they'll be happy without them.
I
Ma'am,
think
I would like to ask.
we are spoiled for
Ma'am.
choices now. No, there are so many choices. Earlier, there was no choice. You just had to put a monofocal and put readers. Yes, sir. Yes, sir.
Ma'am, one more point. If the patient has a small pupil, we are supposed to use a pupillar expander ring, then what would be the choice of the lens? Is it Odyssey lens, Energy lens, or PUC? Because the pupil will not be anyways smaller.
That will answer that.
I was going to say eye hands.
Sir, Dr. Grewal, sir, you wanted to say
Yeah,
something.
when I counsel my patients, I just ask them one question. Do you want rings or do you want readers?
Nice.
Rings are readers. That's good, sir. Good one.
So they would want readers and not rings.
And I hope you're not giving diamond rings, otherwise they will want that.
Tanvi, how about you?
I think everybody has very nicely elaborated. I think we are really spoiled for choice, but it's very important to understand the patient. And Johnson & Johnson itself has now so many different range of field of visions, and that's the point I think we should all be looking at, is what does the patient need it for. The eye actually may have already a pre-existing good range of vision, and you could just very well do with an eye hands and the patient could be very happy. Or if there is something missing, then pure C comes into picture, and somebody who really wants the world, then the trifocal the lens. So combination of these factors is what I will look for.
Okay. So I think we more or less solved the puzzle. And regarding, eye hands versus Odyssey versus pure C. But in times to come, I'm sure we'll become wiser and with more experience, with more studies, with more randomized control trials. You would agree with me, unfortunately, in the world of intraocular lenses, there are not very many RCTs, and they never like to compare one company's lens with the other, especially in a randomized control trial. They would, like you to do a study in their lens only and not compare it with anything. But I'm sure we all can do investigator-initiated trials and studies and do that, not for the companies, but for us to become wiser and for our patients to counsel them likewise. So I think with this, we conclude the session. We had a great session, and we were able to, like I said, solve this big puzzle, which will be continued to solve in the times to come. I would like to thank all the operating surgeons. I think the live surgeries today's were exceptional because they were truly, truly live, with the inside picture and with the outside and the microscopic view. They were better than the live surgeries, if I can say so. And the discussion was, of course, excellent. Thanks to our panelists and to our operating surgeons again. And I would like to thank J&J, Mr. Sami. You can put your video on for making this possible. And of course, our audiovisual team, as well as Swarnim, who does this live surgery transmission. We would like to also thank, like we always do, Mr. Jaswinder from J&J, who's no more, but who introduced this concept of Surginar, at least to me and to All India Ophthalmological Society. So thank you, everyone, and we can have a picture. Mr. Sami?